everybody. So please feel free to continue getting a bite to eat and some drinks. We just want to get going so we make sure we have the full content of the presentation. It's my honor this evening to introduce Shawn McKenzie, who is the founder, president, and CEO of Ascendian Healthcare Consulting. Shawn's a dynamic and accomplished professional with 33 years of progressive contributions in healthcare clinical operations. He started in this business when he was merely 5 years old. Shawn has worked with management and implementation of business and clinical information systems. As a former caregiver and administrator of radiology and cardiology, Shawn has a broad knowledge base of the entire care continuum, which enables him to effectively assist large and small delivery networks to achieve successes in developing viable long-term and sustainable strategies. Shawn's a national thought leader, speaker, and author on the subject of changes in the current healthcare delivery model. He regularly addresses a variety of audiences on topics of care delivery reform, the associated business models and technology emerging to facilitate dramatic changes in the continuity of care. Shawn is defined by his desire to improve care delivery through the use of disruptive technology, data analytics, and business models designed to develop fluid, secure, and sustainable care. The changing healthcare landscape requires an advisor capable of speaking fluently in areas of clinical delivery, information technology, and business. Shawn is that uniquely qualified resource. Join me in welcoming Shawn.
Oh, they left you out, Naomi.
Shawn.
I didn't do it.
We haven't even started and you're stealing the limelight.
Naomi Mullens, she's a consultant with Ascendian. Dose is her world. Her world is dose. So she's here to back me up because I really have no idea what I'm talking about. Not a thing. No, really. We don't. So we're gonna tag team this thing. Do you have a little clicky thing? All clicky. Okay, so dose. It's all the world. Who was in the last presentation? Okay, so ignore half the slides here because I duplicated. I had no time. Deal with it. Have another drink. It'll look the same. You'll be fine. It'll a little blurry, but it'll be good. Yeah, a little disclaimer. We're going to go a little deeper into the dose world if you did not attend the last session. But this dose thing that we're doing, it is pervasive in our lives. It's taken off. There's nothing we can do to move away from it. We have to embrace it. So let's talk about some of the components around dose management, program, and technology. Naomi's going to be doing a lot of these slides here. Once again, she is engaged in a lot of organizations with the whole dose program development, the concepts, the softer side of the business, the qualitative side of the business, and the technology piece. So, from topics of discussion, go ahead, Naomi.
Absolutely. So some of the things we'll look at is the history and sense of urgency. Why the dose urgency now? What happened? Why the fire drill? What sparked these events, and what are the next sentinel events that we're hoping do not occur, and how do we prevent those? Regulatory and compliance. That's why everybody's looking at these dose solutions, right? Compliance, legislation, penalties. But it goes so far beyond regulation and compliance, and that's what we really want to communicate effectively here today. Radiation safety program components. That's my world, that's our world. Building a framework to support a solution, building a framework to support a technology, making a complete program and putting it in place in your organization.
Industry trends. Let's talk about what's going on out there. The industry trends. There's a lot of great technology vendors and partners out there that are developing software today, and they're doing it in an exponential fashion. And they're on the floor, so please visit them in the expo. But the technologies that are supporting dose management at the acquisition level, and then back at the aggregate level or the enterprise level, or something that you need to pay attention to, they're coming out all the time with new versions. It's really an emerging technology. So industry trends, strategic program development. Let's talk about the components of the development of the program. What does it mean? Just installing a technology isn't going to get it done, I promise you. It's just a box collecting stuff. You have got to act on this, and that's what we're going to be talking about. Is program is all that stuff around the technology, the softer piece of it, the operations side of the business. And then we'll hit with Q&A after that. You ready to go?
Let's go.
Here we go. Oh, that's us. My director of business, my VP of business development's right over there. So this is what we do. We're a full imaging consultancy, vendor agnostic. We're published quite often about this and other imaging related subjects. So you can certainly look Naomi up online. She's done a lot of publishing in this space as well. Let's talk about it. Want to hit it?
Go for it.
I'll take this. Okay, so the history. Let's talk about what happened that generated this activity behind the dose. You can thank California. Anybody, any Californians here? Trendsetters? Yeah, thank us. It was us. Little tiny hospital, Mad River Community Hospital out in the middle of nowhere, was doing some CT on a patient, a very small patient, 23 months old. They did 151 brain scans in 65 minutes. Now, how many CT techs out here? How many former CT techs? Is that possible? I mean, really? Is it possible? But the red light didn't go on, you weren't seeing your images, so we just keep hitting the scan button and the repeat button? I don't know. We're not going to lay blame. The bottom line is this, that this patient, in a period of 65 minutes, one scan of this protocol was about 50 to 80 milligray CTDI. Okay? It was estimated that in the course of 65 minutes, this patient got 12,080 milligray. 12,080. That was a sentinel event. You think? Maybe. Right? Yeah, a little suntan right there on the side of the face, Not good. So that started some of the activity. The other one was at Cedars-Sinai Hospital, and we're not pointing fingers here. This is stuff that just happens. They were doing a CT perfusion, and the protocol had a little change. There was a change in the protocol, and they realized that that change in the protocol kicked the CTDI ball way up, and it didn't get caught for a very long time. Over 18 months, 206 patients, one scan protocol, 300 to 600 milligray. One scan. Okay, so if you're looking at the AAPM and looking at some of the thresholds or the recommendations from the ACR and the AAPM, that's a little high, wouldn't you say? It's a bit high. It's supposed to be right around what, 70? 70. So this was another sentinel event that created some activity within California. The activity it created was legislative. All right, California was the first state to come out with SB 1237 and AB 510, which was the radiation dose legislation. Came out, it was a mess, by the way. We read the first draft of this thing, and I think some of you heard me in the last thing. They actually had an MRI in there. Huh? Yeah, it confused the daylights out of us. MRI, wow. Written by a staffer. Obviously, this thing was so poorly written, but it was legislation nonetheless, and as you know, when you're making sausage, it's not pretty, but it comes out. And they made sausage, and they threw it out there. The problem is, the issue is, that sausage is now making its way across the country. Oh, this is the DLP, the area, and that's not going to help. We figured that out. The problem is that as soon as these things came out and legislation started taking off, so did the media. So the media went crazy on this stuff. The cat was out of the bag. How many techs are in here? Just raise it. Former techs, future techs, wannabe tech. Okay. How many of you have said, hey, to a patient when they ask you, hey, how much radiation am I going to get with this chest x-ray? What was your answer? There's a million of them, but my favorite one is, about 30 minutes in the sun, right? You've heard that. Really? Is that true? Is that a true statement?
Sun where?
Yeah. In Denver, Colorado.
What sun? Right.
On the face of the sun. I mean, what does this mean? The bottom line is, since we can't define it, and we're industry professionals, by the way, this is our job. Since we can't define it, the media did it for us. You can thank them. Time magazine, you can thank Time, 2012 came out with an article that says, hey, one CT chest equals about 7 millisieverts. Well, that doesn't mean anything to us. Those terms mean nothing to the public. In fact, I'd bet you that 7 millisieverts means nothing to most of you. Any physicists in here? You know, okay? But a CT tech can't tell you what 7 millisieverts really means. So the media did it for us, and this is where it gets ugly, right? It's one thing to have a sentinel event. It's another thing to have Time magazine in 2012 come out with this. It equals 1,400 dental x-rays, 240 5-hour flights, 70,000 backscatter airport scans, or 19 years of smoking a pack of cigarettes a day. How are we feeling about it now? One CT of your chest. And this is what the media puts out to the community. So the community now is on fire. Plus we have, earthquakes in Japan, and we've got new scanners at the airport, and cell phones attached to our heads, we're going to get it. It's radiation everywhere. We're all going to just get wiped out.
And one of the key components here to really take into perspective is this is setting the framework. This is setting the framework that we're working in. So it's no longer just our physicists. It's no longer just the radiologist champions. It's not just a radiation safety committee team if you have one in place. It's your patients asking questions. It's the community telling you how much radiation they've received because Time Magazine published it. It's a pediatric patient coming in asking, well, why did you choose to do a CT scan on my son or daughter? Don't you know how harmful that is? Well, out of medical necessity, but you have to be ready and have a framework in place to address these types of communications.
So the cat is out of the bag. We've got legislation, we've got regulation, we've got people looking at us, we've got the media taking advantage of us, not taking advantage, quite frankly, without anybody, without a voice, they're going to speak for you. Ask Lindsay Lohan. Happens all the time. Good media, bad media, it doesn't matter. It's media, right? Not for us, it's not. Not in our profession, it's not. So we got to get a hold of that. But this is what's out there, folks. This is what we're dealing with. Let's talk about regulatory and compliance. This is the stuff that percolated out of our California events, the Sentinel events.
Absolutely. So again, we saw from the beginning California. First you have the state legislatures. You have California draft what they call their policy and their legislation. Like Shawn said, the first initial drafts really took us back. We couldn't quite figure out how so many large gaps ended up in this initial legislation that was meant to be a governing piece of policy and effective piece of policy. Following California, you had Texas. Now they stepped it up. They added a few more components to their legislation, and we'll get into some of those pieces. But first and foremost, you had the state lines. You have JACO. JACO comes around and everybody's ears perk up, right? So now we're not just within these California, Texas, upcoming Connecticut, we're nationwide. House of Representatives, we're looking at NEMA scanners and being compliant. So now we're starting to look at a federal level and tying this to Medicare dollars.
This hits you in the pocketbook.
Ears are perking up, right? So it's not just the patient care. It's not just something going on at Mad River in California. This is something that's going to be regulated. There are policies coming, and they're not just for the one-off, two-off states anymore. It's nationwide.
Incidentally, the legislation in California has been requested and is starting to be adopted in the legislatures of all the bodies in all the states. So that beautiful piece of language they put together is being chewed up and refined now. It has been requested over and over again from different states. So, you can look, if you have a lobbyist or you have somebody who's a political action committee for you, have them look up, see if there's a bill that's running through your legislature to find out if there is legislation moving through about this very, very, very subject.
That's a really good point, Shawn. Actually, you might not see it in your state, you might not see it coming down the lines in your state specifically, but I can tell you there wasn't a state in the union that didn't request a copy of this legislation when California put it out there. They wanted to see what's in there, what's the framework, what are other people doing, and it's being used as a guideline.
ACR.
Absolutely. So we have ACR setting CTDI and DLP recommendations, best practice guidelines. They're communicating what they set as standards, and we're putting those guidelines out there for you to follow. Now it's up to the organizations to adopt those and create their own standards and thresholds and put them into place.
How many folks out here have a program in place? That you have a radiation safety program and you're launching it? How many are sending their data into the registry? Okay? Get started there. Let's just skip all this hullabaloo over here and this ballyhoo. Get started there. The ACR is requesting your data. They're trying very, very hard to create thresholds based upon analytics. If they don't have the data, people go, I'm not going to submit that stuff because I haven't been working on my dose, and who knows, this could be punitive. Well, who knows, maybe it can be. But the bottom line is we can't get anywhere unless we have the data. So get it in there. Send that data in, let them crunch it, let them set some guidelines, because they're trying to help us do our job. So that's just a little thing. Please put it out there to them. Go ahead. CTDI, DLP case studies. This is what the ACR is working on, and a national registry. Please submit. It's just, we need the data. We really do. And there's automated ways to do this, by the way. The FDA.
Always fun, right? So now we're looking at it again on a national level. The point here is a lot of people tend to think, oh, I'm not in Texas, oh, I'm not in California, JACO hasn't really specified. It's coming down the line and it's coming fast. It's going to be nationwide and it's going to encompass everybody.
Yep. So here's the 3 state legislative bodies that are actually working on regulation or have regulation. We have to leave Connecticut out for just right now because I think it's still moving through, but we're going to go over some of the things that California and Texas have adopted. Naomi?
Right, so you're probably pretty familiar with California. We've spoken to it. Other people have spoken to it. Their main focus obviously was on CT dose management. In the midst of this firestorm with these sentinel events that happened, you had the media vortex, you had a call to action, the legislation was drafted. It did have indicators of dictating dose, final report, incident reporting. It was effective July 2012. It had huge gaps in it. What is an event? How does it have to be monitored? How does it have to be reported? Now they've come back, they've revised, they've reissued the legislation. It's a little bit tighter, but if you really read it and try to implement it into your organization, you're going to find a lot of ahas.
Yeah.
Well, that doesn't really state what we really need to do. So again, it's back to an organizational level.
And quite frankly, it falls very, very short of what dose really means. Dose to me is longitudinal. The legislation in California deals with procedural dose, by procedure. So you can have a threshold break procedurally and have to report it. But if you aggregately expose somebody and they're doing the funky bacon on the CT scanner because they've had 5,000 CTs in a year, well, that's okay. I mean, you see where we're going here? That's all right, as long as each one of those procedures was not over the threshold for that procedure. Isn't that crazy? You can thank us again. California. Texas.
So that's California. That's Shawn's state. Texas, that's my state. We stepped it up. We did it a little bit better, right?
Threw me under the bus.
Everything's bigger in Texas, and the same goes with their radiation safety program. So they added a few additional components here. One of them being that they required a radiation safety program to be in place. Part of that radiation safety program mandate is that you have to have a radiation safety committee. One of the key, most important pieces of having a radiation safety program is having an effective, all-encompassing radiation safety committee.
Wait a minute, Naomi. We have radiation safety committee, don't we? Come on, you go over the film badges, right? You throw up a CT, or you throw up a chest X-ray, you go a little high in density. We do some training from it, right? Everyone has one, right? Yes? Yes. Sorry, is this on? Okay, go ahead.
I think he's getting to something. So radiation safety committee. Not only that, but we moved forward from just CT to fluoroscopy. So now there's an entire list of fluoroscans that are also considered when taking radiation dose measurements and including it in the patient record. Another piece that we have in the Texas legislation is that the Radiation Safety Committee must provide education opportunities based off Image Gently and Image Wisely. Make sure that all of your technicians, your radiologists, your ordering physicians, your physicists, everyone on board is participating in ongoing education series and be able to document that and show that. The radiation safety committees, they go down to the wire in telling you who it has to include for different modalities, different scan and exam types. They also tell you that they have to meet, quote, as often as necessary and no less than 14 months. So from what we see here is from California to Texas, you have much more stringent guidelines. There's gaps, yes, there's organizational responsibility to put it in place and set those thresholds, create those benchmarks and make it work. But you're seeing a fine tuning of what we're considering policies and procedures to be in the radiation dose world.
And then Connecticut, once again, CT and rad therapy, it's a waiting hearing in the Connecticut House. So that's to be determined, but suffice to say that these legislative bodies are starting to tighten this up and make it better and better and better. So you're all going to benefit from the wiggly waggly California legislation. It's going to be really tight when it gets to your neighborhood. Perfect, right? Good. Let's be ready for it. The Joint Commission work plan covers everybody. Naomi, you want to roll this one out too?
Yeah, so again, like I said before, this takes it from being a California, a Texas, a Connecticut, a state line border thing to being a nationwide issue. This is JCO. They're going to include it in their audits. They released their standards and their updated radiology standards in December of 2013. These are the highlights. I won't read through them, but they do speak to a radiation dose management program, tracking your radiation dose, making sure it's included in the patient record, being able to pull those records if asked, management of safety risks, considering patient size when establishing imaging protocols. So let's think about our pediatric population. Some people here are from children's hospitals, but some of you are from adult hospitals and medical centers and facilities. Have you considered the various protocols and benchmarks and thresholds that have to be put in place for those populations as well?
So let's think about that for a minute. As we're setting protocols, does anybody here, do you have protocols that say a kid, a thin adult, a medium adult, a not so medium adult, a little over medium than adult? And then what we have, 3 layers of obesity these days, right? We have obese, super obese, and morbidly, whatever. Do you have protocols for all this in your organization? Because if it's based off of one phantom, the CTDI off of one phantom, my BMI might be much bigger. So is that really relevant? Is the CTDI, from a threshold perspective, is it really relevant? It's not. So, protocoling along the body mass index, now you're not going to measure everybody and protocol everybody, but if you're going to need those protocols set up such that you can at least have some parameters on which scan protocol you're going to use in order to get closest to that understanding of CTDI vol or exposure. It's everywhere. Okay, so this is what we see a radiation safety program components being. This incorporates it all, and I'm sorry it's in white there, but it's basically protocols, workflows, risk management, policies, procedures, software automation, education training, radiation safety committee, and marketing. Marketing? What do you mean marketing in a radiation dose program? That's craziness. We don't have to do that. Here they blow them up for you, and we back them off. They're really based on 3 pillars. Automation.
Policies and procedures and workflows. Yeah, absolutely.
These are the core. This is the core to your program. And they're going to come, they have a lot of different components to them, but these are the pillars underneath that really constitute a complete program. All right? The new committee. Let's talk about the new committee. You want to do it?
The new committee. So Shawn asked how many people have radiation safety committees. Many of you raised your hand. I have no doubt you have a radiation safety committee. Let's talk about a committee and who it includes and how often they meet, and hey, who's really responsible for reviewing those policies and procedures? Have we identified that? Do they include a risk management program? Who's included in that? Are we communicating to the techs? Are we communicating to the physicians, ordering physicians, radiologists? You want to include your organization's key stakeholders. So this goes so much farther than just the radiology department. Let's get up there in the C-suite. Let's talk about this from a business perspective. This should include your business stakeholders who are going to drive this effort. It's not just a clinical decision, right? This is an entire program. Risk department and resource, absolutely. Sometimes they don't want to get involved, sometimes you don't want to involve them. But risk management should absolutely be one of your key committee members here for a radiation safety program. A lot of times you might be thinking about, they're thinking sentinel events, what happens if we breach our thresholds, what happens if we have a sentinel event, how do we communicate that out? But as some of you may have heard earlier in some discussions today, when we brought these concerns and the radiation safety program to the risk management team, we actually got a total flip perspective and point of view, where they wanted to know, okay, yeah, what happens in these events? But let me ask you this, what happens if we implement this program and all of a sudden our ordering physicians back off of ordering exams that may be medically necessary? Risk management, conversations you want to have, people you want to have in place.
It's a great perspective. What happens if they stop ordering CTs because of this? They're going to get angry. This does not get in the way of medicine, folks. If you have a compelling medical interest in exposing somebody and it beats a threshold, I guarantee you've done the best thing for the patient because it's medically necessary. But you won't know that it's medically necessary, or you'll know it's medically necessary, but you won't know if you're breaking a threshold until you can measure it and proactively measure it and understand what it means. So if you do overexpose somebody and it turns out that it wasn't medically necessary, what's your argument then? My question is, how do you know? And you should know, and you better be acting on it. I mean, this is what we own. We own this piece. It's our world. The C-suite, I want to talk to you about that. This is something that is really important. Imaging has sort of been forgotten. The electronic health record has really turned into be the biggest catcher's mitt I've ever seen in my life, but imaging's been forgotten. Bottom line, we have very little visibility to the C-suite anymore, right? Your budgets are going into IT, and so this is your opportunity now, because you own this, to make it an enterprise solution, an enterprise program that gets visibility all the way up and down the C-suite everybody because it is an enterprising program and it is important and it's necessary and it's part of the quality measures that you're going to do as an organization. It's a quality issue. It's a safety issue, yes, sometimes, but it's a quality issue more than anything else. So get attention up there.
Information technology resources. This is a given. You pull your IT team in. They're going to be invaluable in helping you understand where you are as an organization. What's your infrastructure? There are different technologies out there that offer different platforms on providing a technology solution for radiation dose management, aggregate solutions, understanding where you are from a technical perspective, your environment, your infrastructure. Who do you want to go into procurement with? What are going to be your questions when you're looking at different vendors and how you want to integrate them into your environment? Down the road, what projects do you have coming up? What equipment are you switching out? What systems are you moving to? Those are all key things that you want to consider when you're looking at implementing a new solution and technology for radiation dose.
Bring your techs in, bring your doctors in, not just a radiologist, not just your RSO. Bring your different radiologists in, your musculoskeletal, your neuro, because the protocols that you're going to be setting will affect their world. They need to understand what you're doing. They also need to understand what the system is, so when they're questioned about the system, they can speak to it. They know it through and through. It's part of their culture, all right? That also, and we're going to be talking about this in a little bit, this offers the most amazing opportunity for radiologists to get back engaged in the care continuum. What a concept, right? Every op-ed, every magazine that you read talks about the marginalization of the radiologists, or we put them in a dark room and they're report brokers, and that's the way they've done business. Well, guess what? This affords them the opportunity of getting back out into the care continuum and be part of that care of the patient, because decision support, and we'll be talking about that in a little bit, based on radiation protection, safety, and thresholds, is owned by the radiologists. They really are. That dialogue is going to be part of their profession. So bring them in, all of them.
You know, you
One
spoke
big happy
to
family.
Extending this beyond the radiologists. Texas legislation
Got to bring
specifically
food.
says...
Sorry, got to bring food, otherwise they won't show up, right?
Texas legislation specifically calls out that Radiation Safety Committee, as I mentioned before, and they specifically have it written in there to include a radiologist or radiology oncologist. So they're urging you to include all the members of your faculty, of your department. Bring them in, get them included, get them on board.
Referring physician staff, they should know what's going on. The CMO, bring the CMO in. They're gonna throw that information out to their constituency about what's happening in imaging and how it might affect them. Let them be aware of it. Bring them in, okay? So that's that one. Okay, so this is the opportunity. Radiology or enterprise, it doesn't make any difference. We have a horrible thing that we do in imaging, and it's kind of, we look in our little myopic world of imaging. The bottom line is that we belong to an enterprise. This is an enterprise solution. It is an enterprise objective. It is a care and quality objective. It is not myopic in the radiology department, in the basement, with everything else, with no windows and lead walls. This moves way beyond us. Take the lead, though. This is a radiology imaging initiative. It starts in radiology, but move it to cardiology. Move it to some of the neuro and the cath lab, and anybody that's using ionizing radiation. Anybody, dental, they use it, right? Occasionally, once in a while. You have a dental x-ray? Isn't that weird? You bite on that thing, it's weird, huh? Right? Right? They have DR too. So get them involved. Bring IT along for a ride. This is not a big, heavy IT lift, folks. This technology is not something that's going to be the electronic health record. IT is going to look at this and go, oh, this is fairly simple. No problem, we can do this. But they also need to understand the technology so that they can carry the technology forward into the enterprise, into the electronic health record, into what we call decision support or CPOE. You know, maybe if a threshold is broken, maybe there's a way to halt the feature and say, wait a minute, you need to consult with somebody because we're exposing them at a high level. Things like that. Bring IT along. It's your job, though. This is it. Okay, clinical technology and workflow. Understand your current workflow.
Absolutely. So I think this is one of the best places to start. I've had so many people approach me over the past several months saying, you know, we look at the technologies, we look at what's out there, we're looking at what they can offer us, but where do we really start? And one of the things I really urge people to do is take a step back. Go back to your organization. Let's look at your workflows. Let's look at your current workflows. How are we going to build a vision on what you want for a radiation dose program if you don't understand what you have in place today? Do you have those mapped out? When's the last time you mapped those out? Do they accommodate all of your new technologies that you've implemented and put in place? Do they accommodate all of your different tech workflows for different modalities? Let's get a good picture of where we are so that we can build a radiation safety program from there.
Right, you're going to baseline your workflow. Your workflow is going to show you where you've got delays. You should be doing this anyway, but let's do it for this kind of an initiative. And it's going to also be able to show you, as you start sliding in some dose-related workflows, what the hindrances are going to be, or what the delays might be, or where it might cause a little catch in the flow. But know your workflow. It's a baseline. Definitely know your flow initially. Adopt a tracking software. Please go out to the expo. They're here. It automates it in the back end. This is not the same as, say, AHRA that's sitting on your CT scanner. I want to be very clear. Dose reduction at the scanner is one thing that you should be doing. Okay? This is a software that sits in the back and automates dose as it brings it into the PACS or into a VNA or whatever you want. It actually looks at it and aggregates it and says, hey, you know what? Per procedure, this is the dose. It can also, there's a lot of technologies that can feed it out as structured report data, get it into the report. I mean, there's a lot of things it can do, but it also provides the management tools and management reports that are critical to you. You do not want to throw 5 FTEs at looking at every dose page in the DICOM header information and writing it down. That ain't gonna fly. And it's 5 FTEs, generally for one hospital, to manage all this. These systems now sit behind the scenes and sit there and percolate this data and provide you reports. And I'm talking about reports like this. Like, which technologist seems to be dosing people the most? Yeah. Which scanner has the highest dose for the same protocol in my enterprise? Now that's a nice procurement thing. When I like to know that, if I'm a pediatric hospital and I'm looking at scanner companies, vendors, and I have these protocols that are all the same because I've locked those down, and it looks like this scanner from this specific vendor radiates at 30% higher than anybody else for the same exact protocols. Am I going to buy that for my pediatric division? Probably not. It's a great procurement tool. It looks at technologists. It looks at physicians. It looks at shifts, hospitals within your enterprise. Which hospital isn't adopting the protocols? Which hospital is dosing higher? And quite frankly, if you start ingesting information from other facilities, you get to see their stuff too. Yeah. That's a nice little thing to know. You know, Johnny's Hair Care Tire Center and emergency room down the corner there, they're dosing pretty high. That's something I'm going to put in my pocket for later. But this is the kind of information that these kinds of systems can provide you. So they're out there. Go look. Pre-exam, post-exam, utilization. And then hit. I'm going to let you have this one, Neomi, because I don't know what it means.
Designing future state workflows. So we've set the benchmark, we've set the baseline, we know where we are. What are we going to do with that? Where do we want to go? What technology are we going to implement, and how are we going to make it effective and useful? So outlining where you want to go with those programs, where you want to go with those workflows and technologies, what efficiencies do you want to put in place? How is it going to be designed to bring value to your organization?
Great. CT protocols, okay. How many people here have their CT protocols locked up? Wow, excellent. So I can't go in there as, tech on the night shift and go, you know what, I think I'm just going to change the pitch. I'm going to do this, I'm going to do that. Can I do that? Okay, good. Do it on the fly anyway.
You can. Anybody can change their pitch and all that stuff on the fly.
Sure they can.
They can't change the protocols unless you give them their instructions.
But the CTDI, the dose page is going to show everything, right?
Yeah.
Guess what? If you have an automated system, they're going to go, wow, why is this one on that shift way up here? Well, that's because they changed the pitch, and they changed the MA, and they did all this different stuff. They shut off the AHRA, whatever. So it's really good to know this stuff. Lock them down. Protocols, we talked about some of the requirements around protocols by body size. Okay? Use different phantoms. Not 2. Use a bunch. They're out there. Okay? Set the protocols based upon that stuff. Lock them up. Your committee should be determining protocols. Remember, you want to get best image quality with lowest dose. Don't go for all just dose reduction. That'll make your radiologist completely wacko. They have to read these things. So it's a nice mix. And every time there's going to be a protocol change it, but make sure it goes through committee so it's understood and locked up. Okay? Make them standard as best as possible. Update to meet the ACR and AAPM recommendations. You go on their website, they'll tell you this is the scan protocol, this is what it should come out for CTDI, eyeball. All right? This is about where you should be. Go on there and try to hit those. You know, you may be below them today. You don't know. But know what they are. Know those thresholds. Know what they recommend at this point. Good image quality, we talked about that. CT device evaluation for vendors and standardized through the enterprise. And that's that one. Good. Go ahead.
So what to look for in a solution? This is where we are. A lot of us are here. We want a solution. We need an aggregate solution. We want to take this manual process off our plate and be able to pull those reports. All right, so what do I start looking at out there? Like Shawn said, you have the vendors here. Go visit them. They're on the floors. They'll show you their product. You'll probably be amazed at some of the things these people can do and what they can do for your organization. Take a lot of that manual process out. Make it easier on your physicists, your clinicians, your policymakers, your policy keepers. System integration, inbound and outbound information transfer, integration with existing technology. Again, what do you have in place? Where are you going? What updates are coming down the road? Let's include all of that in our discussion. Understanding the questions you need to ask of these vendors if you're looking to implement this solution, this technology into your environment. Patient dose management. Looking at aggregate dose management, what does that mean to you? What do you want to include? How many of you bring in studies from outside hospitals or facilities? You put them in your packs, right? So are we going to include that in our aggregate dose calculations? Or are we not? Are we going to separate it out? What's that going to look like? Assessing all of these different assets that this technology can bring to your organization. Looking at the different dose values and types. So we have CTD eyeball, we have DLP, we have air kerma. What are we going to measure? What do we look at? What do our physicists look at? What's important to us? Do these technologies offer all of those measuring capabilities? How do they present them? Is it in a way that we can speak to it to our ordering physicians, to the clinicians out there? Can we create a useful message from it? Dose management reports, Shawn spoke to this, all the different ways that you can use this technology and this automated solution to drive reports, to drive procurement, to drive performance evaluations, to drive education, to drive your policies and procedures where you need to make updates and changes, and proactive dose notification capabilities. So then moving into clinical decision support. How are we going to roll that out, and how are we going to message it out to our ordering physicians, and who's going to be the decision makers? All different things to consider when you're looking at the technology.
Yeah, these notifications are great. If you have an enterprise solution and you're not just a standalone, or you don't have an individual PACS, but you have a enterprise-wide PACS, maybe it sits at that level. And you're able to look across your enterprise. So when a person who's a frequent flyer, and they come in, and they've had 5 CTs over there, and 7 CTs over there, and 9 CTs over there, your RIS may or may not provide you that capability of seeing that. Okay? But your dose software will say, wait a minute, man, this person's had, you can set thresholds on amount of CTs in number of days, on radiation exposure thresholds. There's a lot of ways you can set alerts. And maybe this alert creates a decision. Maybe we should do something else. Maybe we should use something that's non-ionizing, some other modality, an ultrasound or an MRI. Or in California, an MRI is radiation emitting. Haven't you heard? So forget that. Let's go to ultrasound. Okay? But it gives you that decision support capability. And now you're actually engaged in deciding and creating care for the patient. It's really cool stuff. It's good reports. RFP, know what you're going after before you start putting functional requirements into your RFP. Know what you want. Know what your ecosystem is, because they're all going to be a little different. Know what you're trying to get to. Talk to the vendors. They'll make you crazy with information. It's good stuff. Start vetting through it. Here's some of them right here. You'll find some of these on the floor today. Some of the bigger ones. There are emerging companies that are coming out, but these are right now the players in the market that are out there that have general release, general marketed technologies today. Okay, once again, all a little bit different, all do a little different thing, a little touch and feel, different architecture, but these are the ones that you could probably visit at the expo today.
And stay engaged with them. This technology is changing so fast. I mean, they're on a monthly basis, they're rolling out updates, revisions, enhancements. They're listening to the community. They're listening to their clients that they've installed at different locations, what they're wanting, what's valuable, what's not. This technology is changing so rapidly. Stay engaged, reach out to them. If you have a new requirement come up or a new question come out, reach out and ask them, can you do this? Can you perform this? Do you have this calculation? Because they might not have last month, but they probably do this month.
Right. Okay, policies and procedures. It's imperative to develop and define roles and responsibilities along the entire pathway from order to outcome. If you don't know what your role is, and when there's something that happens, you've got to know what to do and who's going to do it at the time. You don't want to model around on this stuff and skip on this stuff. You want to know it's got to be locked in tight. So governance, pathways, policies and pathways. What's the governance committee look like on this? Engage lots of different key stakeholders in governance, those decision makers on what we're going to do. If this, then that. Know these things. Codify this information. Get feedback. Get input.
Build on that radiation safety committee you created. Have them interactive. Have them proactive. They should be the gatekeepers. They're watching these policies and procedures. They're responsible for updating them and improving changes to them. Put them into place here.
And what's the new role of the radiologist? They were talking about this. Anybody go to RSNA? Heard of Imaging 3.0? It used to be where we get paid fee for service. So the more reports we could jack out of there, the better. I just get paid, I get paid, I get paid. How many people are engaged in the ACO, have an ACO, or looking at episodic or at-risk payment structure? The government is. Okay? Your CEOs are. Your CFO is very, very concerned about ACO. No more fee for service. It's going away. And if people think it's going to get washed out with the rain or the administration, you're wrong. It's going to continue because we have to do it. The ACO basically says this: we are going to measure and pay you for quality outcome, lack of duplication, patient satisfaction. These are what we're going to get measured on. So there's a bucket of money that gets distributed over an episode, a patient episode, and if you cannot show value, you don't get paid. Kind of scary, huh? I mean, who's going to figure this stuff out? Well, this is an excellent time for the radiologists to come out of the dark room, out of the reading room, be consultative. They live in this stuff. This is dose. No one else is going to do it for them. They have the secret squirrel decoder ring. They can go speak doctor to doctor and all that kind of stuff. It's time for them to move out and say, look, I'm going to manage this dose thing. And when there's an issue or a question that comes in, I'm going to manage it from a professional's perspective and get out there and be engaged in the patient's care continuum, actually in the care of the patient by making decisions collaboratively with ordering physicians, hospitalists, or whomever. Okay? Got to get out. This is the perfect role for radiologists to get out and be consultative again. I mean, we own this. This is good stuff. We don't even have to make it up. So it's a good time. Processes.
Yeah, so this goes so far beyond breaching thresholds, beyond those alerts that are going to pop up in those automated solutions you've just implemented. This is looking at your low-dose protocol standards, but also at your maximum low dose with image quality. Shawn spoke to this earlier. We want to bring the doses down. We want to set those benchmarks and thresholds appropriately, but we want to make sure that radiologists are able to read and they're able to do their job and they're able to deliver the effective patient care while still maintaining these thresholds. So absolutely keeping that in mind.
Thresholds. Corporate thresholds, we talk about that.
Right.
That really is a corporate decision. I mean, the ACR and the AP, I'm going to give you guidelines, but it's a corporate decision. You might want to lower them from that. I can tell you that we've done work with Bethesda, Walter Reed, and they have the Wounded Warrior program there. And they're not under any delusions whatsoever that when Wounded Warriors come off a theater and they go over to Europe, to Germany, and then they come back to Walter Reed, they have had hundreds, and I'm talking hundreds of scans from a traumatic brain injury or some sort of a nasty trauma. They get scanned. So they've actually got a different set of policies and procedures and a different set of thresholds for the Wounded Warrior program because they know they're never going to meet standard thresholds.
And they've actually taken a step farther than that, Shawn. They've put it in place to where they not only have these standards in place, but they have 3 levels of them. They have a green level, a yellow level, and a red level. So they've set standards at 3 different levels of policies and what those thresholds should be.
And what happens with each?
What happens with each, absolutely. And even at the mild level, at the green level that they've set, considerably lower than what you're seeing published by ACR guidelines and recommendations. So I think the big take home here is yes, there are guidelines and recommendations. Yes, there are policies and procedures, but these policies and procedures have to be driven from an organizational level.
Right.
They have to come from you. They have to come from within your healthcare organization. You have to set your thresholds. You have to set your standards and what you're going to abide by and what those alerts are going to look like. Yes, there's guidelines, yes, there's legislation, but it doesn't tell you where those standards should be. It's up to you to build those policies and procedures.
And then communicate it. Communicate it out to the physicians. Communicate your program. Get it out there. Let everybody know that you're aware of it, that you're tweaking it, that you're working on it, that's part of your culture, that you've made it part of your culture. Talk to your patients. Get it out there. Let them know that we're actively and proactively checking this stuff. And we really are engaged in your care at this level. That's a good communication plan. Make sure that you have that in place. Those policies are, how do I communicate with my professional staff? How do I communicate with my patients? Better yet, policy, how do I communicate with the media? When they show up at the door and they walk into the CT scanner, because we don't have any kind of, they can walk freely through the hospital, right? They find the CT scanner, they walk into your CT tech and say, hey, listen, remember were you on last Tuesday? I just got a call from a mom who said, you cooked the baby. And the CT tech goes, I what? No, nowhere to go. What's the policy? Media, patient, physician, questions, communications. Have that policy in place. Tracking and reporting dose exposures, regulation, state, federal, know what to do if you have to report something, who does it, how does it get done, who follows up. Collaboration between departments. That's a good one. Collaboration. They should know your program. Mm-hmm. ICU should know your program, that you've got a program in place, that these things are being watched. Okay? Communication and education and training. When you say pool, make sure everybody understands what you're saying. All right? No ambiguity here. The program has got to be very succinct and very clear. Okay? The ambiguity in communication it's profound in healthcare. We use acronyms until we use acronyms. Our acronyms have acronyms. And we do that because, I don't know why. We're just acronyms. It's terrible, right? Right. Down on the down low, right? So, create an internal and external communication plan to the patients and family. What are you going to say if you have a threshold break?
Who's going to say it?
Who's going to say it? What are you going to tell mom? What are you going to tell dad?
What do you legally have to tell mom and dad?
There may be state regulation that says you have to tell them X, Y, and Z. Well, okay, listen, you've got 7 millisieverts on that. See ya. I'm out of here, What does that mean to them? Don't let them figure it out on their own. Have a communication strategy to these people, all right? To the ordering clinician, they're going to want to know that you exposed, you had a threshold break. What does it mean? I can't explain it. Maybe my physicist can do a better job. Maybe the radiologist needs to get engaged to have that dialogue with the clinician to talk about the plan going forward. Maybe it was purely medical necessary. Maybe it was an exposure or overexposure because the patient moved and you need sedation. It can be a million things, but have the dialogue. Make sure you have the dialogue and know when to dialogue. And of course, to the media, you're going to have a word for them. Train the staff to answer questions from patients and family. They should know your system through and through. They should know your program through and through. Okay, what will my exposure be is a good question. That's going to come up more and more. What will it be? Do you have an answer? Is it a made-up answer? Is it something that you're going to control, that dialogue, and how that gets put out there? Okay, control those things. Am I safe having this procedure? That's another one we hear a lot. Am I safe? Well, sure. That's the fallback answer. Sure it is, and this is why. There's always a, yes, of course you are, and this is why. We proactively measure this. This is a program. We've been doing it for a while. We measure everything. We look at it before you get your scan. Everyone should have that right on the tip of their tongue. They should know what the program is and why they're safe. It's not enough to say yes anymore. Got to give them a why. Ensure staff understand all the components of the program, all of them. If this, then that, it goes there, it goes there, it goes there. Train them. Okay, risk. You want to handle risk?
Absolutely.
Yeah,
risk management. Right back up there to quality and value, right? Bringing the risk management team. We touched on this briefly earlier. Ensuring all patient incidents are properly addressed in timely and complete manner. Now, some states, some regulations outline exactly what your time frames are for this, who it has to be communicated to, when what has to go out. For others, it's not. Understanding your dose incident management and what's going to be included, understanding the determination of retrospective analysis. So bringing those different people in on the conversations. Have we evaluated this? How are we going to be proactive about it in the future? Managing the preparation for Joint Commission. Again, JACO, they've released their updated imaging requirements. They're coming down the road. I heard earlier that some people were looking into a dose radiation program and backed out on a rumor that JACO wasn't really going to go through with this. They're not really going to follow this through. I warn you to be very careful with that because they are. They've made it very clear.
Yeah, you probably should find out. I don't want to base any decisions on rumors that I've heard out there. Oh, they're not going to do it. Yeah, they're going to push it a year. It's like ICD-10. One more year. It'll be fine. Well, good luck with that. Have fun. Okay, and last one is marketing. Market your effort. Make it known. This is a flag to put out there. If you are engaged in a program and that program is effective, you want to let everybody know. You want billboards, and you want guys wearing sandwich signs and girls wearing sandwich signs, the funny pickle thing dancing or whatever, saying, hey, we've lowered the dose, we're paying attention to it, get it out there, it's a media event. Market this stuff. It's great. You're actually doing it, but don't market it if you're not doing it, but let them know, let the whole world know that you're doing it. Market it to patients and family, to the ordering physician, to the media. Make it part of your brand. Make it cultural.
And be proactive. I think that's one of the big keys here. Be proactive. Get in front of your patient population. Let them know up front that, oh, you have a question about dose? You don't have a question about dose? Well, we've thought about it. Let me tell you how we've thought about it. This is what we've put in place. Bring it to them. Don't wait for them to come to you and ask.
Every website, every publication, it should be known. We're doing this. This is how we do it. We're always aware of it, and it's always evolving. It's something that we have brought into our culture. Very important. There's a good examples of companies out there, of organizations out there that are doing a great job of marketing the daylight side of this system. Good job. Okay. My question, if asked today, can you explain your current program end to end today? You are the management. Can you explain your program end to end? Can you explain it to your C-suite, to the media, to the Joint Commission? Take your inventory. Look at your inventory. What do you have today that even comes close to matching up to what is expected? Okay, I'd rather be on the high side or on the far side of the bell curve than on the back side of it, personally. So if you ask yourself this and you can't explain your system end to end, then you got to do your homework. It's time. It's time to do it. Can you define the gaps if you do have one? Okay, we've got one, but we've got some things to improve. Can you name them? Where's the fallout points? Okay, and then of course, who really cares? I'm serious. In California, they've had legislation for 2 years?
2012.
2 years. And I can tell you, probably 80% of the healthcare organizations just don't care. They have no program in place. It's law. It's law. It's not like you can wear an orange jumpsuit, you're going like on death row, it's, hey man, what's up? How'd you do, man? Well, I exposed somebody to radiation. I really hated it, but it's not gonna like that. But there are fines, there are penalties. They've done nothing. A high majority of them know nothing. They have no idea. They can't explain a program. They haven't even bought the software. They got somebody with a spreadsheet, the CTDI on that patient was this. Who knows? So it's not getting any juice. Eventually it's going to get some juice. I'd get ahead of this curve if I were you, personally. Okay, industry mistakes that we find everywhere. You want to do it? Because you're out there all the time. You've seen the mistakes everywhere.
Automated solution. We're good. We're compliant. We have a system in place. We put the radiation dose in the patient record. We're good. We don't need a program. Okay. Well, you've spent a nice little penny on technology. You've implemented it. You've crammed it down people's throats. What's your ROI? Where's your value? How's it working for you? Do you look at the data, or is it just a big box of data sitting back there somewhere?
Yeah. If you collect it, by the way, the Jacobys and Myers of the world, those lawyers, that are going after the asbestos right now, they're just drooling on this. They're waiting. First person that goes, hey, you know what, my right arm fell off because of overexposure to radiation, I know it. They're going to grab a hold of that. They're going to go straight to the source. And they say, can you please show me aggregately what you've exposed this patient to? Might take a day or two. I got to put together. Okay. Well, we'll subpoena those documents later. How about this? How about you have a system in there and it's available in the system and you haven't checked it? You're not even using it. It's just collecting. I met compliance. Great. Okay. This is going to be a field day, folks. I don't like scare tactics, but bottom line is, this is the asbestos waiting to happen, man. This is radiation exposure, and the media is not going to let it go. So be aware of it. Lack of education. Role-based levels of education required. There are different education levels for different roles. What, the booze run out or what? We run out of alcohol? All right. Ordering physician communication. We're going to move through this, apparently. Patient communication, you know, that's something that just doesn't happen out there. We don't communicate with our patients. We don't let them know. It's okay. It's okay. Informed decision support. We don't do any decision support around this stuff at all. I mean, that I know of. Some places do, but you know, if it's coming in and this order comes in, it's an HL7 message, an order message, and all of a sudden we go, "Ooh, threshold." What do? Do we get in front of it and suggest something else? It's very rare. A lot of mistakes, a lot of trends that just don't happen. And not doing community outreach and marketing, that's a big one. A lot of that just sits in a box, collects data. This is what's missing. You want to go over what's missing in the industry that they're working on?
Pediatric dose, so back to patient size, looking at different protocols, different levels, different threshold breaches, pediatric dose management guidelines. There are a lot of children's hospitals out there setting standards, working on a radiation program, communicating those out. Again, just like the adult situation here, we don't have specific published legal standards that you're stuck to. It's an organizational issue. You've got to create those, and you've got to make sure that you're addressing all of your patient population.
They're giving us the axe. The big hook's going to come out and pull our heads off. Okay. You can read them. Effective dose values, that's a big thing. We're using CT-DIVOL. We need effective dose. We understand that they're working on that. Contrast dose for that extravasation, 150 milliliters of, it blows out in their arm, so we hit them again. Good idea. Kidneys love it. All right. Inclusion of other modalities. We're working on CRDR and MAMO. A strategic program for development. If you're a big enterprise, start with one, bake the product. Get it baked in there, bake the policies, bake the procedures, and then move it. Scale it around your enterprise. But start with one. Start with one modality, if possible. Okay, step into the spotlight before the spotlight finds you. I recommend it. Get in front of it. Any questions? We don't have any time, so see you later.
Thank you.